Welcome to everybody. I'm just kind of looking through the roster of everybody who got on board today. I know we're going to miss a couple of people, but we do have the vast majority, so that's awesome. Okay, well, this is the third session of 3, as Kiona mentioned. So again, nice to have everybody here. A couple of things. If you've got your computer volume on and you're using your phone, make sure you turn that computer volume off so we don't get any feedback. Otherwise, we're just going to plug forward. Here as a reminder is a group of the group of everybody that's been participating in our learning collaborative. For those of you who missed last week, just a reminder to listen to that session. I think it'll really help in terms of the one-on-one that we're scheduled to have, but then also just some background information, particularly on objectives and measures, since those are key to your evaluation process. But this is everybody who has been joining us, so welcome to all of you. And as we get started here, I just want to remind everybody kind of how we've progressed through this process so far. So we've talked about the project focus areas. We've talked about stakeholder involvement. We've talked about SHIP goals. We've talked about stakeholders, kind of setting goals and answering questions. We've talked about creating SMART objectives. And then during, at the end of last session, we talked about creating measures. We actually did get through that particular session. Today, we're going to talk about some highlights from some of the work plans and dashboards from the one-on-ones that I've already been able to conduct. I've had 3 one-on-ones and great stuff is happening behind the scenes of the Learning Collaborative. So I'm really excited to showcase those 3 states today. We're going to then move on to collecting data. We're going to talk about determining impact, and then we'll conclude with some next steps and additional resources. So I do have everybody scheduled for one-on-ones. If you haven't already had one, one of the things that I will note as a part of that one-on-one process is that once we have our one-on-one, you'll have an opportunity to go back and make some adjustments, work on your work plan, work on your evaluation plan. And we can either communicate a little bit via email, or if you prefer, we can also set up another one-on-one to do a follow-up if that is more helpful. So you're going to be able to decide that. We'll talk about that in terms of your one-on-one session, but you'll be the driver in that as we move forward with those in terms of what your needs are and what you're looking for in terms of just kind of assistance and being able to adjust your plans and stuff. In terms of the one-on-ones, I am going to, as I said, we're going to listen to those folks who have participated in a one-on-one already. And we're doing that on the front end today versus doing that after we've kind of wrapped up all of our evaluation topics. And the reason being is because I really think that it's helpful to everybody to kind of hear about the different programs in a little bit more detail, but then also to hear kind of what their evaluation plans are and some lessons learned from the Learning Collaborative or from the one-on-ones, because that will just help you in terms of going into your one-on-one, but also thinking about kind of program development and some of the options that you might have if you're thinking about making some changes to your SHIP program. So during those one-on-ones, we talked about, kind of questions that folks are trying to answer. We talked about objectives and goals, and we talked about creating measures and objectives, the differences between inputs, process outputs, and process measures. Gathering data from contractors was a big topic across all 3 folks. We talked about data and use. We talked about stakeholder input. We talked about tools to support reporting and data collection. In fact, I created some tools for folks to kind of get the ball rolling. And then we also talked about just kind of building an evaluation into program operations and just kind of the importance of getting started. any one of those themes rolled through one or all of the one-on-ones. And I anticipate that when we have our one-on-ones during the rest of this week and next week, that you're going to find that a lot of these topics are covered as well. With that said, we are going to roll right into kind of some brief overviews from each of our states that have already done one-on-ones. And we're going to start with Cassie in Iowa. I think actually Cassie's got a really interesting program, the way it's getting administered. It's a little bit unique. So as we kind of walk through these, Cassie, Barbara and Misty, I don't think Sarah's on yet, but Barbara and Misty, are you guys both on? You're probably on mute.
Yes, Barb is on.
Okay, great. So then we'll have you guys go, and then Danette, we're going to conclude with Danette. This is Danette's second round in the Learning Collaborative. So Danette can kind of also talk about how her evaluation has evolved, and it's evolving from last year into this year. So Cassie, do you want to just kind of start off by talking a little bit about your SHIP program, give people a little bit of understanding. You've got some unique things going on in terms of your RFP process, and then talk about what your plans. I know that you're in the process of developing those plans, and we talked a lot about that yesterday, but just kind of what you're developing, and then any takeaways that you had from that one-on-one discussion. Any kind of key points that you thought would be helpful for your evaluation and evaluation development.
Yeah, so for Iowa, we work with Hometown Health, and that came about due to the requirement for us to do an RFP process. So they were the awardee of our SHIP program administration piece of it. For evaluation plans, as we kind of talked about, Rochelle and I, our measurables are kind of more like participatory things. So how many people participated in a certain webinar and things like that. But definitely want to kind of get more meaningful data going forward. And as far as like progress reporting and getting data from the contractor, we do quarterly reporting through this internal system that we use called Iowa Grants. And it's not really the most helpful information that we're getting. It's not a lot of data. It's more like narrative updates to their work plan. So definitely want to incorporate more like figures and measures into that. And so I think that's also kind of the takeaway from our discussion. Rochelle gave a lot of good examples of how to kind of track things and kind of what measurables to use. So I think a takeaway from that is just getting ideas of different things to do and kind of making a more meaningful template for that reporting.
Great, thank you, Kathy. Can you talk a little bit, can you provide a little bit more information about what your project actually looks like? In terms of just, numbers, because you have a lot of SHIP hospitals, and then also the different buckets that Hometown Health, which is, I believe it's a nonprofit that went through that RFP, that won the contract in your RFP process. But can you kind of give a little bit of background on what your project looks like?
Yeah, so we have 82 critical access hospitals in Iowa, and about 90 are SHIP eligible hospitals. So through that, 79 completed applications for SHIP. So that's really a big reason why we don't ourselves administer the SHIP program, because we would have to go through 79 different contracting processes for the hospitals. So Hometown Health offers a consortium, which is what most of the hospitals opt into. I think in the year that just ended, I think all but maybe like 10 or so hospitals chose to go that route. So with the consortium, they kind of offer like pre-formatted like projects. So they'll have the work plan and everything and the budget all set, so the hospitals don't have to worry about that piece of it. If there's not a project within the consortium that the hospital would like to implement, then they would go the quote unquote direct award route, where they would develop their own work plan and budget, but still that is issued through Hometown Health. They would be responsible for paying out those claims and monitoring the work plan and the budget of those hospitals.
For the hospitals that are getting,
And
then, Cassie, for the hospitals that are getting the direct awards, what are the majority of them getting those direct awards for?
I would say the majority of them have a piece of technology or software in mind that they would like to use the funding for. So I would say that is probably what it's utilized for most. But the other good thing about working with Hometown Health on this is that they have a lot of like discounted rates that they get. So even if a hospital chooses to use a direct award to purchase like certain hardware or software, a lot of times Hometown Health will have a discounted rate for them. So by going through Hometown Health, it's a benefit to them.
And then will you also talk about the the way you meet with your the partners that participate in this process on a regular basis? I know that came up in our conversation as well, the way you're meeting, and then how you may use the evaluation tools and integrate those into your meetings.
Yeah, so with SHIP, we only work with Hometown Health as the contractor, but for Flex, different parts of Flex are contracted out to different contractors. So our Iowa Healthcare Collaborative has the quality improvement and population health piece of that. And then Hometown Health has the financial and operational piece of that. And so we meet monthly with both IHC and Hometown Health on the same call, just to kind of give updates and stay in the loop and make sure nothing's duplicative amongst Flex and then among Flex and SHIP. And so I think going forward, whatever tracking or measurable tracking evaluation plan we choose to use, I think that will kind of be almost like our agenda for our monthly calls, and just going over those and seeing kind of pinpointing what hospitals may need additional support, which ones are doing really well, and kind of going through any future plans or ways that we can help each other out, or maybe kind of reach out to hospitals and get some more participation.
I really liked that idea of, I know a lot of our programs are, especially if you're working both in the SHIP and the Flex bucket, but that opportunity to be looking across both programs at the same time using the evaluation tools. I really like that idea. I mean, that was a win for me too, in terms of thinking about the projects that I work on. So I thought, wow, that could be really helpful. And that's definitely something that any of us could incorporate into just kind of operations pretty easily.
Yeah, and I will say too, Rochelle, that one of the examples you showed me of how you track participation per specific hospital, I actually had a call with Hometown Health today, one of our regular monthly calls, and they actually have a tracking spreadsheet like that. It's just nothing that we've ever asked for or thought about asking for. So that was good to see that they have been doing that. It's just that I guess we never thought to ask for something like that.
Oh, awesome. Terrific. Good. Does anybody have any questions for Cassie in terms about her, her program, things that she's working on, some ideas that she's come up with? Any questions for her?
Hey, this is Renee in North Carolina. I have a quick question. Can you hear me?
Yeah, go for it, Renee.
Yep.
When you say consortium, when you're like a majority of them participate in a consortium, what does that look like?
Yeah, so that would be really, consortium is just kind of a pre-formatted project for them. So basically we have the work plans already developed and the budget's already developed, and they just kind of have to go through the steps. So that's kind of what it entails. And then in addition to kind of pre-formatted projects, they would have access to different educational opportunities too, and different meetings that we offer.
So your pre-formatted projects, are they like, do you have a lot, or is it a pretty simple list?
It's a pretty simple list. I could share that. I could pull that up and kind of just like give a few examples, but so one was like care coordination training, Lean Six Sigma training, on-site quality consultation. So that'll be part of it too. They'll offer the option to do like on-site consultation, and they will subcontract with different organizations and consultants to provide that option.
So Cassie, is it almost like a menu of opportunities that they can participate in? So you might have, so you gave the example of care coordinations, you might have 15 hospitals that want to participate in that particular training and learning, et cetera?
Yes, that's correct. And those were just a few. I mean, like the list is pretty lengthy, but and how they identify which offerings for the consortium is they do a survey each year and kind of assess what people are actually interested in, and then given that information, they'll develop these consortium menu items.
Any other questions for Cassie?
Hi, this is Leela from Florida.
Hey, Leila.
Hey, I have a couple. So is Hometown Health a nonprofit organization? So
I believe they are, yes.
Okay. And you mentioned for your flex vendors, Hometown Health is one of your flex vendors as well, and then another organization called Iowa Healthcare Collaborative. And were you saying that you actually have calls with both of those vendors together to share information?
Yes, that's great. So this isn't something that happened previously. So before this year, the current year's Flex program, we worked with Stroudwater and Hometown Health and IHC, and there was just a lot of disconnect, and no one knew what each other was doing, or it caused a lot of confusion with our hospitals too. So that's kind of our goal for this year for Flex and SHIP, is just kind of touching base more and making it more of a like cooperative project and program.
And that's been working fine, like two different vendors working together and sharing information. You've had no problems with that?
I haven't. I know it can be tricky sometimes, just like because they're competitors a lot of times, but it hasn't been a problem yet. I will say sometimes I do get calls from just one of the contractors, and kind of we'll talk about things that I can tell maybe they don't want to share on the call. But I think for the most part, for the big picture stuff, they're always willing to share and cooperate with each other.
And Hometown Health, what's the difference? Which one does which piece of Flex? Hometown Health does what, the quality piece or the finance, or?
Yep, so they do financial and operational, and then Iowa Healthcare Collaborative does quality improvement and population health. And it really works out nicely because IHC, Iowa Healthcare Collaborative, hosts our HIN. So they do a lot of the quality data collection.
Okay. And then just one more question about, and this is me being new to the Office of Rural Health and SHIP. I've been in the position for a little bit over a year, but in terms of, well, Florida does individual disbursements right now. We only have about 16 facilities that qualify for SHIP. Usually we only have about 10 or so that apply and participate. But again, they're individual distributions, but I'm wanting to go to something like, you know, some kind of collaborative, either the Florida Hospital Association or Hometown Health or someone else kind of managing, administering that. Like in terms of operationally going from, you know, individual distributions to having an organization manage that, I know that that takes a while given the application process for SHIP and that kind of thing. I don't know if anybody has any thoughts about that or if I'm jumping the gun on asking that type of question.
I think a number of programs have tried to move in that direction, especially as their, you know, as their programs have moved forward. Does anybody want to chime in on that before we move on to Missouri?
Can you ask the question again? I'm sorry.
Just about moving from the one-on-one funding to more of the consortium or joint projects, you know, making that leap from individual grants to, you know, project-based kind of initiatives.
So this is Kyle in Wyoming, and I agree. I would like more information on that as well. We also distribute our money directly to the hospitals. And I think it would be a lengthy process because they are used to getting it directly. And so now to say, well, you're not going to get it. So what do the conversations look like? What do the conversations with the hospitals look like? And then what does that move to some sort of collaboration look like? So I am in support of getting more information around that too.
I think it's a really big question, and it's one that comes up a lot during these evaluation conversations. I think it's it's going to take a lot of time, and I don't want to take all of our time from the rest of kind of what we're going to be talking about today. So Kiona, I don't know if you could put that kind of in a parking lot. Maybe that's something that can go on to task as an opportunity to do just even a webinar or a conference call where that's the SHIP focus. I know there's a couple of states that have made the change. Candy, I don't know if you're online, but I know that Louisiana made that change a few years ago. Iowa did make the change quite a while ago before Cassie was there, but you know, providing some support since a lot of states are wanting to move in that direction.
This is Danette. We did this in like it was back in 2009, 2010. I started in 2010. So my CEO is the one who did that transition. So I could ask her if there's something that she could provide. If anybody wants to have a conversation with her or whatever, I will check on that.
That would be terrific, Danette. And maybe even follow up and just send it to Kiona.
Yeah.
Because I know there's a few folks on the chat. I think Renee, you guys in North Carolina, you're making that change this year. So I think there's a lot of folks, even, you know, Renee, you might be able to sit in and provide some, you know, insight on what that looks like and how you're proposing to do it.
Can you, before we move forward, Rochelle, what was the question again?
It's not really a question, but it's a topic. It's really kind of support for SHIP programs who want to move from direct hospital grants to kind of project work. So, you know, developing consortiums, having cohorts, it's things like that, moving away from these direct one-on-one grants to kind of project-based initiatives.
This is Cassie. I apologize. I have to go to a different meeting, but I do have a suggestion if there's some sort of educational offering around that to maybe incorporate some like examples of scope of work from people's RFPs. If I'm guessing a lot of other people too have to go through the RFP process, but just to give some examples or a starting point for if they need to do that.
That's a great idea. Thanks, Cassie. All right, so we're going to plow forward since we have a lot of things still to cover. Let's go to Misty and Barb in Missouri. Do you want to give a little bit of background on your initiatives? Also talk about what we've been working on some evaluation plans. In fact, I can pull up kind of the start of the plan that we've started working on. I'll go back to that. So talk about kind of your plans, what you're developing, and then any takeaways that you had from that one-on-one discussion that we had.
This is Barb, and Misty, Sarah, and myself were all new. The longest tenured person is Sarah with like 6 months. So everything we're presenting it's an inherited project. We do contract with the Missouri Hospital Association, who works with our SHIP eligible hospitals. We have 49 eligible hospitals, 46 signed up to participate in FY20. So we're getting closer to 100%. And that's one thing that MHA is working on, is trying to get all eligible hospitals to participate in SHIP. They offer TA to the hospitals as part of this contract, and they work with them to make sure that they are utilizing the categories appropriately, all that administrative work. They also have our Flex contract, so that allows them to provide webinars and do that crossover for critical access hospitals topics. If they're also a SHIP topic, it can hit the same hospitals. And that's one thing in talking with Rochelle on our one-on-one was how to tie that all together in our evaluation to use the biggest bang for our buck and not focus just on the SHIP dollars, but what's that crossover so that we can show what we're doing and working with MHA to collect the data in that manner. So we learned a lot talking to Rochelle, and actually after our call, we went in, updated that document more, Rochelle, so we'll send you a new one. We beefed it up a little bit more and really targeted to what Misty and I have been talking about. Because right now, what we inherited was a process measure, and we want to go to really what is happening in the hospitals so that we can show HRSA what their money is really being used for, other than, yeah, we dispersed the dollars. What did they do? Did the ICD, something change in the ICD process? The bottom line, what's our true story? So we're learning a lot and appreciate Rochelle's help. And Misty, if you want to add anything, please go ahead.
I mean, I think you've covered it pretty well. I think the biggest thing is that is working through the kinks between us being new to the program completely, and the Missouri Hospital Association just took over this contract at the beginning of this last grant year. So it was just, I mean, it's been a learning process since we've all started, and then it's been a learning process for Missouri Hospital Association. So I think just, you know, the more time and energy we put into this, the better and the program will be, and then the smoother it will run as well.
I thought it was really great the time that you guys have taken to really kind of understand your program, because it was clear as we were talking that you guys were really just kind of running with developing the evaluation components and thinking about, okay, how will these pieces fit together, both within SHIP, but then also in Flex. And, you know, just the fact that you guys had taken that time to really understand your program, I think really helped in terms of being able to move this pretty quickly forward. Does anybody have any questions for folks about what they're doing, what Misty and Barb are doing in terms of their evaluation work and their program? All right. So we are going to go then to Danette in Colorado. And again, do you want to kind of give some highlights of your program? Talk about some of your the evolution, just a little bit about the evolution of your evaluation that's being developed, and then any, this is your second one-on-one that we've had, so any kind of new takeaways that you may have had from your one-on-one?
Sure. In Colorado, like I mentioned earlier, we moved from the full payout for purchases and individual grant projects to a consortium or the network model. And so since 2010, we've been operating on a network model, and each year we build on what was done or accomplished in past years. So we've come through the ICD-10 implementation. After that, it was basically business 101. We looked at, okay, something as big as ICD-10, let's go ahead and address those business issues. So we went to revenue cycle workshops, revenue cycle workflow. That opened up kind of a can of worms with patient access training being needed. With another grant, I also did EHR user group calls, and from that we found issues that the hospitals needed to address with their EHRs. So a lot of what we do in SHIP is based on what's already going on in SHIP, what the current needs are of the hospitals, and what discoveries we've made through other programs that we're doing with hospitals. And that's collaboration with the Flex grant and other grant programs. So that's how we've come to the current status. So we have a menu with the network model. We have a menu that we require them to do priority 1, which is HCAHPS and ICD-10. So there's a budget for those. And then we work with a contractor to provide the necessary training. And ICD-10 touches every kind of coding, CPT, E&M, HCPCS. It involves a variety of things. So we have really pulled things in and work with a really good vendor to get that accomplished. We also have a vendor that we work with. We have vendors for the priority 2 selection, and we have 3 items in that area, so they can choose one of those items. We've got about 12 hospitals in the EMR workflow analysis for data accuracy project. And we've got about 12 in, or a little more in the Charge Master project. And then there are, the remaining hospitals are part of large systems, but they're small rural hospitals. So they don't have, they're on Epic, so they don't have control over what's going on with their EMR or their Charge Master. So we have an alternative for efficiency training, and it's quality improvement or lean training, and then they design the project that they want. They come up with a topic that they want, and then our consultant works with them on that. And that works really good because with the network model, we pay the consultants directly for the work. We work with them to gather make sure the deliverables are completed, and they each do an evaluation. So we gather that data that we're looking for. And then I dug a little bit deeper with HCAHPS because we've accomplished 100% participation with HCAHPS, but we want to go beyond that. We don't want to just sit here and count hospitals that are doing something. That's a checkbox mentality, and we want them to do more than check the box. So we want to dig deeper into the data, into what they're doing with HCAHPS. I developed a little matrix that I've used for follow-up in this past year, and it's helped them understand how to give me back the information I'm asking, because a lot of them kind of freak out or they kind of freeze in their tracks. If I say, we want measurable data, they freak out and people start saying, well, I'll have to run some reports for that and I'll have to do this. I'm like, no, I don't want complicated. I want simple. You know, let's talk about what you're doing. What are you measuring? And so I'm actually this year when I'm updating my my project charters, I put a little example in there. You know, you started your project with 352 broken widgets. You want to reduce the number of broken widgets per month, and you implemented your project, you implemented some improvements, and by the end of your project, now you only have 100 broken widgets. And I show them how to do the math and show them how to figure out their percent of improvement. So that's been a learning process over the past year. The other thing that has happened over the past year is additional follow-up calls, just getting on the phone and chatting with them, chatting through that project charter, and getting all the pieces and parts that are part of the deliverables. We want to see their action plan. We want to see what they're working on and how they're working on it. And the biggest thing for me is that I want them to understand what their data means and how they can use it. We've had some pretty funny scenarios over the past several years where that has indicated that our hospitals are just looking at, oh, it's time to do that data. We just have to get that data done. And then they move on. They don't think about it. They don't look at it. They don't get into it. So really helping them get into their data and understand what it means, and particularly in HCAPS, helping them see what that means. And for the one-on-ones, the one suggestion that Rochelle made that really, that I really liked was, rather than looking at the HCAPS scores in the small hospitals that have small patient census, and that adversely affects their HCAPS scores, it's off balanced as far as statistics. So she suggested measuring with time. So if they're doing great, getting positive positive surveys for a certain length of time, and then they get a negative, then measure the time between that negative response and the next negative response. And she said that the longer the time in between negative responses indicates their improvement. And I like that. That really helped me think outside the box. And I think that is what has really helped me from this second class, is to be looking at the programs in a different way and thinking outside the box, to look at the measures differently, because that's what I've wanted to do. I don't want to keep using the same measures or evaluations each year. I want to change it up. I want to help them get value from doing their projects.
Well, thank you, Danette. And I think, one of the things that we all kind of have to manage within from an evaluation standpoint, HCAPS is a good example, is when we're talking about, some of our hospitals have less than a third of a patient a day. So if they're getting only, maybe 6 or 7 surveys back in a year, what can they really work on if they see their peaks and valleys in those measures just constant? Is using time as an opportunity to measure improvement. Also, another one that we talked about was survey response rates, for them to really kind of work towards whatever benchmark you've set as a state. I usually use the top tier, the top 5 The average of the top 5 is kind of my benchmark that we're working towards as as an area that we can have it for improvement too. So I think that point of just kind of thinking outside the box is a really good one. Let's see, Danette, Penny has a couple of questions for you. One is how much State Office of Rural Health FTE is devoted to your SHIP program? And then number 2 is how much money does each hospital receive? I think there's some variation in terms of how your funds are used. So do you want to talk about how you split those funds, but then also the FTE?
Sure. The FTE is just one, and that's me. With dividing up the money, we don't necessarily give the hospitals money. They allocate, we do the SHIP grant, we write the grant, we request the amount for each hospital, and so we write the grant on behalf of all the hospitals, but they fill out their applications and select their activities. So we develop a budget for the activities. So each activity, so HCAPS, the billing and coding training, the charge master, the quality improvement, the EMR workflow, each one of those items has a specific budget. And so with EMR workflow, we pay the consultant directly. We have a budget per hospital. So we work with that contractor to do the work we want for that specific amount per hospital. So initially we went out and checked on different pricing and whatnot. So that's how we handle one. We pay the contractor. With the quality improvement, we do the same thing. We have with the charge master and the HCAPS, they have the choice of working with their own vendor or like in charge master, their own consultant. So then what they do for that is they submit invoices and check stubs to us. And then, but we have a budget set. They don't get everything reimbursed. We have up to a certain amount that they get reimbursed. And so that pretty much takes care of it. And I don't know, what else do you need to know? What else can I tell you? Does that make sense? Does that help?
Yes, thank you.
Okay.
Awesome. Thanks, Danette. Any other questions?
I have a comment on the difference between how we did things with, giving a whole chunk of money back to the hospitals after they do their own project, or what we do now with the consortium. I managed that last year of it in 2010 for the 2009 SHIP grant, and it was not fun. It was a mess. And so I really like the consortium way that we're doing it much better.
Great. I thank you for sharing that. I do think that a lot of folks would like to move in that direction, just especially states that have a large number of hospitals, but even some of the smaller states like Kyle, I know that she's been wanting to move in that direction as well. So Soleil has a question for you, Danette. Can you tell us a bit more about how you use data to share information with hospitals, and how has this strengthened your evaluation plan?
I think the charge master activity this year is a good example, because it's the project charters that we're using now that really steps through the deliverables and helps them figure out their baseline, their data focus and their baseline, understanding that, whatever they want to fix, we help them figure out, well, what is it about that you're going to measure? And then so they get their baseline established, and then at the end, we do follow-up calls, which has been a huge thing, and we're going to beef up that. But at the end, it's like they have a disconnect and they don't understand, well, we're not really measuring anything. Well, yeah, you are. If I can talk to them for 5 minutes, I show them what they're measuring, how they can get their numbers, and then how to figure out their improvements. So so we work with each one of them individually to look at what they're doing, how they're doing it, and then help them figure out what that data focus is. And I'm not sure why it's so hard sometimes. I think because they're thinking conceptually in what I consider a text mode, and they're not thinking about numbers. Does that make sense? So getting them to, you know, put a toe in that water, so to speak, and test it out, and then jump in and really get into the data and understand, how does the data affect what they're doing? How does the data show them that they're improving? Does that make sense?
Mm-hmm. Yeah.
This is Penny. Can I just kind of tack on the parking lot topic is really relevant here about moving from individual purchases or individual hospital activities to more of a real project focused SHIP grant. And as part of that, I would love if there was something in there about how to convince hospitals to participate in, like Danette, and really everyone else who presented as well. Thank you so much for sharing. I've loved hearing about what you guys are doing. It always gets my idea juices flowing, but then I also think back of the reality of what I know about our hospitals. And we have trouble convincing hospitals to participate in a project where we give them $20,000, $25,000. So the thought of being like, no, we're not going to give you any money, but we want you to participate in this program. We want you to write an evaluation plan. We want you to collect data. We want you to measure outcomes. Like, the thought of putting all those necessary and fantastic activities on the hospital, and you're not giving them any money, I would love for maybe a discussion about that somewhere down the line.
I think that's what my CEO could contribute to, because she took care of that part.
Awesome.
So I will talk to her and see if she can help.
Yeah, I think, Penny, you're right. It's a really, you know, how to make that shift. And in some instances, I don't know that if it was, you know, all of the funding moving in that direction. I think in many instances, it was groups of hospitals moving over and some still being able to remain on those one-on-one grants. I think that's the way it is in Iowa right now, that there's like, I think she's got like 12 hospitals that still get the one-on-one grants, and then everybody else has slowly moved into the consortiums. But that's really one of the big reasons where this having some evaluation data available can help drive in that direction. If folks can start seeing what the outcomes are for the hospitals that do participate in the consortiums.
Great.
All right, so we are going to move on. Everybody knows that you can reach out and contact one another. If you're in the process of working on any of this, and you heard somebody talk about something that kind of strikes your fancy or is in an area that you're working on, I highly recommend just reaching out to people so that you can get some ideas and get moving if that's kind of the direction that you want to go. And then Kiona will follow up on the task side in terms of some of the ideas that you guys presented in terms of some additional sharing and learning, etc. All right, so everybody just got some ideas of kind of where some of our programs are at, what they're working on from an evaluation standpoint, some of the tools or ideas that they took away from their one-on-ones in terms of moving forward. But we're going to now get back to kind of the evaluation planning piece, just so that I can walk through a few kind of key elements as those of you who have had a one-on-one, so that you can kind of start fine-tuning things. But those of you that are going to be going into your one-on-ones that you can be thinking about as you start developing your evaluation plan. So this slide it's a concept in terms of evaluation work that is currently occurring. This happens to be some evaluation work that's occurring in Texas surrounding ICD-10 coding and billing. But I think there's a couple of important concepts on here in terms of work that they're doing right now that is helpful to point out. And one is this process indicators section, where they really engage their hospitals in terms of identifying some of the process indicators that the hospitals would be using in terms of kind of measuring success for this particular initiative. And that all of these process indicators tie directly into the outcome indicators that they identified. So if these processes aren't happening, the hospitals believed that if those process changes aren't happening, the hospitals believe that those outcomes can't be achieved. And the more of those processes that change and the more success that they have in those, the more likely they are to move towards these positive outcomes. So as you're kind of thinking about all the different indicators that you're going to be considering tracking as you move through kind of this evaluation process, really thinking about the linkages of what it takes in terms of outputs and process to get to outcomes, and then eventually to determine whether you've had any kind of an impact using the funding. Any questions about this concept in terms of an evaluation plan and ideas of stakeholder involvement? All right, another thing that, that we talk about in more detail during the one-on-one that I wanted to point out today is just a reminder of a lot of you have kind of program operations measures in place. And I think a lot of that ties back to the contracting process. But if you're going to include some of those, if you've achieved success, you really can move away from making that a focus of your evaluation plan. Some of you may want to still track that, you know, each hospital and that those tasks have actually occurred, but they may not be priorities within your evaluation anymore if you've actually achieved them and your process is working really smoothly. Just thinking about kind of operations and process, you want to include these in if you're still challenged by that, or it's still, you know, a priority because of issues that you have in your own internal process. But you can start moving away from it if you don't. But if you are working on it, really to have to have your measures, your objectives really fine-tuned in terms of what you're trying to achieve or any questions that you're trying to ask, making sure that those are really deliberate and not vague and broad. You'll be much more likely to get there. You'll be much more likely to be able to identify then which hospitals does this just apply to one hospital? Does this apply to multiple hospitals? If it's one hospital, then you want to be able to target that one hospital. If it's multiple hospitals, well then maybe it's the approach that you're using. Maybe you're going to need to have regular, more frequent webinars or conference calls or updates or emails in order to connect with people. All right, so we have talked about, we've gone through our goals, we've gone through our objectives, we've created measures. Now we're going to go into another piece, a few other pieces of the evaluation process, collecting data, using the measures, and then showing impact. In terms of collecting data, if you haven't looked at the SHIP evaluation guide, make sure that you look there. There's tools there. There's definitely a lot of background information there And so make sure that you look there. I am going to be providing a few highlights from the guide, but I'm not going to be walking through everything that's available in the guide because I think there's easily 10 different data collection concepts in the guide. So as you're developing your plan, it is really important to figure out where you're going to get your data from. In some instances, it may be data that you already have. It might be data that you have to get. It might be something that's coming through directly through your SHIP program. It could be something that's coming through your FLEX program. Identifying in your evaluation plan, identifying your data source and who's responsible and working together as a team to make sure everybody's on the same page will just assure that everybody is working together in the same direction. If you go into the guide and you look at the different data sources that you can be looking towards or looking for in terms of using as a part of your evaluation plan, you're going to have primary data, so that's data that you collect or have already collected, so it's in-house information, or secondary data, data that you've gotten from other folks. So it could be data that you've gotten from vendors, it could be data that you've gotten from Telegen, just really depends on where you're pulling it from. When you're thinking about your data, there's obviously all levels of data and that's needed. And some of the data that you're collecting could be reactions and feelings. So if you're doing some kind of a satisfaction survey that focuses on satisfaction, that's going to be more reactions and feelings to something. If you're looking at learning, what was learned by an individual, or if you're looking at changes in skills. So was there a change in skill? If you're teaching a class, you could be doing pre and post test surveys. If there's changes in policies and program services or finances, that's going to be more at the organizational level. But in essence, the further that you move down this list, the more that you're moving towards outcomes versus just thinking more about outputs and kind of behavior, philosophy, things like that. So if you can move forward down this list, you're going to be in a better position to actually have quantifiable data that you can use to measure changes over time. There are lots of different tools, as I've talked to different SHIP programs, different tools that folks are using in order to collect data from their hospitals. I believe this one is from Kansas, and they have like a pre and a post survey that they send out to all of their SHIP hospitals. So they have a year start and year end where they're asking different questions. They do this in paper format, but there's nothing that would stop you from doing something like this online using SurveyMonkey or another tool that you might be using for that. But doing pre and post can be really helpful. I've heard a lot of people talk about doing satisfaction surveys at the end of the whole program grant year related to courses. I highly discourage spending too much time on just straight up satisfaction, particularly way after any activity has occurred. Because the closer that you gauge people's philosophies to the time that the activity actually occurred, the better the measure is actually going to be. Versus if you are doing something that happened a year after the activity occurred, what you're really measuring is oftentimes you're measuring somebody's thoughts and feelings on that particular day. It has very little to do with the activity that was actually conducted, and it has more to do with their feelings on that particular day. The other thing is we've moved away from just kind of satisfaction, unless you're trying to learn some basic things about, oh, you know, should we have this particular vendor back in to do a presentation, but more about what was learned, what behaviors have changed, how have we changed our policies and procedures internally? What have some of the outcomes been? What has changed internally? What changed in terms of your bottom line? What changed in terms of your, could be a patient satisfaction survey, really thinking more beyond just perceptions of a particular event and more about changes across the organization and behaviors in general. Surveys, questionnaires, checklists, polls, pre and post tests, working those right into your operations is terrific. It makes it much more labor, less intensive. I know that everybody's got really, you know, there's not a lot of staff time dedicated into most of the SHIP programs. In fact, in some SHIP programs, it's almost non-existent. So if you can have, you know, if you're using a contracting work out to a vendor, if you can contract, or if that vendor can have built into their process and as a part of their requirements to fulfill any reporting requirements that you have, any evaluation needs that you have, that's just going to be data that you can pull and that you can use as a part of your process. And so I'm going to give you an example of one that I do on the Flex side that's really been super helpful for me. I showed a couple of you guys yesterday this, but so I facilitate a trauma course. It's the Rural Trauma Team Development course in one of the states. And when I contracted with that vendor, what we agreed to is they would do a pre and a post test. So I get pre and post test data on every person that takes that class. And then in addition, I created a survey about experiences in that class that they talk about. And then they also talk about, then I also ask questions about what some of the changes they're going to make in their hospital based on what they learned from the workshop, but then also what some of the barriers are from that workshop. And with all of that information, since I am getting pre and post test scores on individuals within the hospital, I'm able to track those scores over time because we will go back into that hospital, 2 to 3 years down the line and do the training again. And oftentimes those same individuals are there. So I can see retention in terms of knowledge, changes in terms of knowledge, but also in terms of what they planned to change for their facility. I turn around and I take those responses and I do a follow-up survey that's three months later and ask them about those changes and whether they were implemented. And then in terms of the challenges for implementation, I take those comments from that course for all of the individuals. And when I do site visits, I talk to the CEO about those comments and challenges that they said that they had in terms of their ability to implement any of those changes into that hospital. So as you can see with that, just one example, all of the different layers that I can take that little bit of data that I just got from the vendor and translate it into a lot of opportunities for improvement, measurement, and change across the whole program. Any questions about that one in particular, since I know a lot of folks are doing surveys, questionnaires, checklists, polls, pre and post tests? All right, does anybody have any surveys or questionnaires that you have built right into program operations right now that you want to share with folks? Anybody feel like sharing any questionnaires, polls, or pre-tests that you guys have built in? I think, Penny, you guys have some questionnaires or polls that you guys are using. Don't you use those in some fashion as a part of your program?
I knew you were going to call me out. I like felt it coming. Yes, we do. And it's actually fairly new to our program, but the full disclosure, it was really more tied to the administration of the grant. And it was kind of my sneaky way of getting in some evaluation or assessment, really. And so we we have what's probably unique. You guys probably have no problems getting your hospitals to submit invoices or whatever paperwork they need, but we have trouble with some of our hospitals getting what is required, getting what we need. And so we structured an intentional quarterly outreach to our hospitals. And again, we have 64. So there's a handful that are no problems, like they are on top of it. But the majority of our hospitals require some level of handholding, some quite a bit. So anyway, so a structured quarterly check-in, and as part of the third quarter check-in, we're implementing a sort of a satisfaction survey, and I would love to share it, except that it hasn't been fully developed or finalized yet, but I'm happy to when it is done. And then, so the satisfaction piece of it, and we also, with each of the quarterly check-ins, depending on the level of need or hand-holding, we either do a phone check-in or a email check-in. And because we don't want to because for those hospitals that purchase something earlier on in the process, we don't want to wait until the end of the grant to say, hey, what changed as a result of that purchase that you made, 9 months ago? So we also build in a question on those quarterly check-ins as far as what changes have they experienced as a result of the purchase. And then we do a final year-end survey that kind of formalizes that question and asks everyone to tell us. It's very similar to what Kansas had, which I like. That was to explain how the SHIP funds were used to address a need and what that need was, and how the SHIP funds helped. So we never use the word evaluation or outcomes because our experience has been that freaks people out. So.
Good. And I think that you are a heavy user of Qualtrics for your surveys. Is that true?
That's true. I'm even certified in, I'm an advanced user. So yeah, we are really fortunate through our association with the University of Wisconsin to have access to a license to Qualtrics, which just has a lot of really great features. And actually our SHIP year-end survey, we're building it right now. And we've built it so that depending on if they did because we have, just a quick reminder, we have most of our hospitals do an individual purchase, but a little bit fewer than half are participating in a group project. And so we have it set up that depending on which category they fall into, that determines what questions they see, because the questions are slightly different. And then we also are able to pipe in a lot of information, like, you told us you purchased this product, tell us about it. So we're able to customize and I think get better data because of it.
Yeah, that's really, actually, that's really cool. And I think that would be very helpful to folks to be able to even see what that looks like. Tapping into something like Qualtrics or SurveyMonkey and using it even as a database for your program. It's a really easy tool. Any of those are really easy to manipulate and to use both, throughout your entire process. So really think about that. And as you said that too, Penny, another thing that came to mind is the Wisconsin Office of Rural Health hosts a data summit each year. I'm assuming if it's held this year that it'll be online, but that's another place where a lot of sharing about just kind of data use across state offices of rural health is happening. Lots of good information is shared. I participate in those. It's a really, really great opportunity to share and learn about new tools and how people are using them. So that may even be a plug on to share that, Penny, at that upcoming data summit.
Yeah, thank you. And a quick note on that, John still hasn't put out anything official, so you guys are the first ones to hear the news, but we are officially canceling the in-person event this year. And we're gonna do an online version or a virtual version, but we haven't quite worked out the details. It's not gonna be 3 days because, oh my gosh, can you imagine? I forget about it. So, so we're working that out as far as what does a virtual event look like that's meaningful, that's engaging, and we've always kept the group size pretty small to make sure that as many people actively engage. It's more of a discussion. It's not a learning summit. It's not a sit and listen and learn. It's really it's about engaging in discussion. So yeah, we're actually participating in the No SOAR call this afternoon about virtual meetings and hoping to pick up some helpful tips on that. So anyway, we're going to be trying to get information out about the unknown data summit soon. So.
Perfect. Awesome. Thank you. All right. Another opportunity, and a number of people talked about this today, are using interviews and focus groups. An area that I've gone to more regularly these days is using, instead of, a focus group or interviews, something that's bigger, is I've shifted even into using huddles. So really targeted knowledge, learning, and sharing. And they can be really short. Sometimes they're only 15 minutes long. I've done that a lot on the quality improvement side of some of the initiatives that I've been working on. And it really gets people to engage quickly, give me the information that I need, and leave. But the other thing that is really kind of nice about using more of a huddle format to gather data is that I can do it more regularly. Everybody probably knows that, lots of folks are constantly getting surveyed, and, they have so many meetings, etc. But being able to do some really short and tight data collection where they don't have to, they can just, pull it and give it to you and run, may be another great opportunity. Focus groups are, if you've got initiatives, if you've got funding going out to a number of hospitals, and but they're around the same topics. So you may have funding that's going out to, for example, hospitals for their HCAP vendor. Being able to sit down and talk to folks about, why was it important for them to get that funding? What barriers existed for them to not, pay for that straight outright when, 95% of the hospitals across the country are, paying for that vendor automatically as a part of operations? What was it that made that important? And then also, having the conversations about, so what is that funding meant in terms of their ability to work on quality, to engage folks in that patient satisfaction improvement process. And then obviously tying it into the need to use that data in order to make improvement. But sometimes just sitting down with folks and having a focus group around some specific topics can not only get you the outputs and outcomes information that you need, but it also can help you develop your program from a needs assessment standpoint, and what are your stakeholders thinking, and where do they want to go, and how, and what are they almost, I'll say, willing to do in terms of moving forward and developing their organization along with the goals of the SHIP program as a whole. Is anybody using focus groups or interviews right now as a part of your SHIP evaluation, or even your flex evaluation? And I should note that in terms of that recommendations adoption progress interviews, those RAPs, the center task has information related to that, some details on being able to do that on their website. So I would look for those there too. Secondary data, don't ever forget about the secondary data that's out there that may tie into what you're working on. Leverage this. I mean, obviously the MBQIP data is really, really helpful. There may be other data in your state. Each state has different data reporting requirements that you can tap into. In Wyoming, for example, we rely heavily on QHI for financial reporting in particular. Our hospitals report about 22 measures monthly on their financial performance. So that's a great place for us to tap into any of that financial data. any other secondary data that you guys are tapping into that might be of interest to other folks? Stephanie, I think that you guys have an initiative with your hospital association. Is there anything, is there a data source there that you guys are tapping into? I think that that one is financial as well.
You're talking Stephanie in Idaho, right?
Yeah, Stephanie in Idaho.
We're doing a financial initiative with Flex to get real-time financial data, but I don't connect it to SHIP. I think part of my challenge is I use, because we're a government entity, we never do anything very easily, but so we have Key Survey instead of SurveyMonkey that we're allowed to use with external people. So we do like a progress report, a final progress report that we've modeled after the SHIP progress report sort of application, because they used to have a progress report back in the day, and then ask for their deliverables, what are some key outcomes based on their project. But I think my challenge is trying to compile it, because it seems like for every hospital that does something, there's something different that's reported out. And so trying to make a kind of comprehensive picture for FORHP to let them know sort of how funding was used, I think is kind of a challenge sometimes. I almost wish there were more of a, and this will kind of fly in the face of what Danette's talking about, because I don't want process measures either, but I wish that if there was a certain type of initiative, you'd have kind of certain types of outcomes to kind of bank on, which doesn't necessarily happen. But I think it's a good question about maybe trying to pull the financial indicator project stuff that we're doing. The hospital association just houses the information, but I work to get the CEOs or one of the CFOs actually, or one of their minions to enter the data quarterly. And it's just based on the top 10 indicators. And there's a lot of elements that go into those, but we try to kind of have it look like a cost report, pulling into those same items so it doesn't take them that much time. And then we use that for benchmarking. But I don't necessarily tie it to SHIP at all, because it's mostly a Flex initiative, and the way I entice them is whenever I have scholarship opportunities, like if I have cost savings or I know I'm going to have cost savings, then if there's like a HFMA, like the Healthcare Financial Management Association, or even some of the AHA and like national conferences, now probably everything's going to be virtual, but those kinds of things, if they want to try and get a scholarship to that, then they have to be consistently entering their data into this sort of repository. So I'll have to look into maybe seeing how to connect that to SHIP. I haven't really thought about that.
Yeah, so when we have our one-on-one, we can maybe peel back some layers to think about, is there any data in there that relates directly back to some of the projects that are getting worked on? And I would recommend everybody just kind of thinking about that, because especially, you know, if you're working on any initiative related to the financial improvement of hospitals, you know, any financial data that you have that relates to that could be an opportunity to use it versus asking them for that information again. In particular, if you're getting it over time and they're working on those same initiatives as a part of SHIP for multiple years. So think
Okay.
a lot of us will be still having one-on-ones over the next week and a half. So, you know, if you think about those data sources, we can tie into that when we have those conversations. Thanks, Stephanie. The other thing that is important is just the data tracking piece. You know, how are you going to track your data? I know that you can track it in a database. I use spreadsheets a lot just because of the universal use of spreadsheets. Some of you I've already created some spreadsheets for to give you some examples of what might work for you, but really think about data tracking and the ability to merge data. I think a lot of our programs from vendors in particular, we get Word docs kind of describing what they did, which then means you have to take all of that description and translate it into data that may or may not be helpful. But if instead you gave them a data tracking form that specified exactly what you're looking for and is consistent across each one of your vendors and you and everybody else, and you can merge that data so that you can be looking at the measures comprehensively, you're going to be in a much better position to both use that data and actually having more accurate data, so you're interpreting it. And if there's any, as we work through these tools, this is definitely an area that we'll work on. So we've spent a lot of time talking about kind of the performance management and evaluation and moving forward with all of your evaluation plans. I like to tie all of that back to kind of program improvement and this whole kind of PDSA cycle that I think all of you are familiar with. We talk about it a lot in quality, but it really, this same kind of mentality, this same approach to improvement is no different for us as it is for our hospitals in terms of doing improvement. The steps are very similar. It's just kind of walking through planning, developing your activities and measures, collecting the data, analyzing it, and interpreting it, and then taking that information and using it again for developing your program plans, deciding kind of what things are gonna look like, how again you're gonna measure it. So I think sometimes for folks, when I put this PDSA cycle in front of you, since so many of you use it already on the quality improvement side or even on the operational improvement side, that's really the same thing that we're doing as we're working through this whole performance management process. It's using those measures, it's collecting the data, it's building plans, it's understanding what's going on with our programs so that we can act, make changes, and make things better. The kind of final step in all of this evaluation work is really kind of that impact piece and how your outcomes can be directly attributed back to your program. And, the more you can directly relate your activities or what's going on in your facilities back to your activities, obviously, the more accurate your reporting is going to be able to be. And being able to say that there's a direct relationship between participation in SHIP and advancing the goals is really, what you're aiming towards. If you want to move into really kind of looking at your impact, and I know that we're all kind of at the beginning stages, but I'm going to throw this out there anyways, just in case some of you guys plow way far ahead, is that once you have the data on your hospitals that did participate, you can compare it to the hospitals that did not participate. And you can look and see, were there changes that happened in the hospitals that participated that didn't happen in that control group that did not participate? And really, that's kind of where your evaluation starts taking on a new shape, a new way of looking at things. What did you do within your program that contributed to that versus, what didn't happen in the non-participating hospitals that maybe didn't make those advancements, or it could have been that there's certain changes took place in this basket that you were working with. Those similar changes took place in the basket of those that you weren't working with, but there might have been variables. There might have been issues within that basket you worked with that wouldn't have translated from where they were at to where the others were at just because of finances, staffing, etc. And understanding that will definitely help in terms of our ability to move our hospitals forward, but also to support them in with what is working and what doesn't work, given the characteristics of the hospitals that made the movement. So the impact piece is more complicated and definitely more time consuming, but that's really kind of where we're going as we work towards creating thorough, comprehensive evaluations for all of our programs. So I'm going to wrap it up with all SHIP programs should have some evaluation plans that include collecting performance measurement data, using the data for performance management, reporting, continuous improvement, kind of that PDSA cycle that we talked about. And then the program impact analysis and reporting can be added to create a more comprehensive high value evaluation. So it just, that end piece is really kind of where you're at, how developed your evaluation plan is. In some instances, you may just decide to work on that impact piece with a small part of your program, or even a part of your program where you invested a lot of resources and where you plan on investing a lot of resources moving forward. So we've got a little chat here. All right, so that is it from me. I know I'm going to be meeting with all of you. We have 1 minute, so I'd like to just see if, I think Soleil left. Sally, Angie, Kiona, anybody that have any final comments, anything else that needs to be shared with everybody before we close today?
Hi, Rochelle, this is Angie. Yeah, I guess I would like to just thank everyone for their participation in this spring's SHIP Collaborative Learning Collaborative series around program evaluation. And as we close up this series, we'd like to assess everyone's knowledge gained over the past 3 weeks, as well as ask for feedback on the overall learning collaborative. So Jesse is going to post 4 questions. So if everyone could take just a moment to answer the questions, we would really appreciate that.
I think we should have had the baby on there much sooner. Beautiful baby, Renee.
I'm like, what baby? I can't see it.
But he was supposed to be napping, so.
Aww.
I'm gonna say that's not happening because he looks like he's right awake.
Yeah, I'm being difficult.
You are not sleepy at all.
That's so funny. Stephanie, when you said that, I was looking at my slide, I'm like, there's no baby.
You're like, there's a big fish, but no baby.
I know, I'm like, are you talking about the baby fish?
I saw Kyle get all bright over there and I was like smiling too. So thank you very much.
Jesse, did you put up all 4 questions?
Hey, I just want to say something about the baby, and that is my babies are all adults now, and I love that you get to bring your baby to work with you. That's awesome. That's great.
Yeah, it's about time.
I think, well, we're still at home.
Oh, I know.
Oh, you were, yeah, okay. I was just saying, like, what are we on, day 80 though? So, I mean, it was really cute for the first couple days.
Hey, Rochelle, you're going to have
Yes,
trouble
ma'am.
interpreting the responses to that first question because you're not going to know if our increase was, it's going to be difficult to interpret. Is my thought. I've already submitted, so I can't remember the exact wording. Oh, there's that baby. I couldn't see what everybody else was talking about. Now I see the baby. You don't know what.
I don't see any of the. Oh, there's the question.
So you're going to have trouble interpreting the response about whether or not how much it increased.
Okay. Well, and these are all questions that come from I say task, but from the center. These, honestly, these aren't my questions.
Sorry, I didn't mean that as a criticism. I'm sorry if it came out that way. That was just
no, that's okay.
Reaction.
Has everyone seen all 4 questions? Yeah.
No, yes. Where are they? Are they in the chat?
I've only seen 2 questions.
Okay, Jesse.
You'll have to scroll down to see the other 2 questions, and the polling should have automatically come up on your screen. If you have 2 screens, it might be on a different screen or somewhere.
Got it. Found all of them. Thank you.
So while everyone is finishing up the poll questions, I just again like to thank everyone for their commitment and your participation in our Learning Collaborative series. Thank you to Rochelle for the wonderful content and all of the knowledge that you shared with us. The entire Learning Collaborative series, playbacks and slides will be shared within 5 business days. So please look for that email communication that will come from Fiona Hermanson. In the meanwhile, and as always, if anyone has any questions, please feel free to reach out to us at shipta@ruralcenter.org. And with that, we thank you again for your time, and we look forward to connecting with you all again very soon. Thanks so much, everyone.
Bye-bye.
Yeah, thank you, everybody, and thank you for the opportunity. And just as a reminder, Kiona, there were the 2 items that came up for future kind of training opportunities, the one today and then on the first webinar. So we should touch base on that as well.
I will remind Kiona of that. She had to leave to take baby Sutton to a doctor appointment.
Okay. All right. That sounds great.
I will share that with her. All right. Thanks, everyone.
All right. Thanks, everybody. We'll talk to you this week.
Great training. Thank you.
Bye.